नमस्कार मैडम।
नमस्ते सर।
आज हमारे YouTube चैनल में मतलब दोनों रंगगंध कला सत्यान्यास और शल्य शोभा स्त्री आरोग्य ये दो हमारे चैनल्स है। वो चैनल में आपका बहुत स्वागत। डॉक्टर शिवलीला जो है आज पहले हमने डॉक्टर प्रकाश मेहता साहब से बात की कि जो हाई रिस्क प्रेगनेंसीज के साथ डील करते हैं और प्रेगनेंसी और मदर के साथ उस बच्चा बहुत जुड़ा रहता है एंड न्यूनेटल केयर इज आल्सो वेरी इंपॉर्टेंट जॉब एंड rather it is more important job because it continues for few days or few months sometimes. तो वो जो जॉब है वो डॉक्टर शिवलीला इस अस्पताल में देती है। ये हम अभी भगवान महावीर जैन हॉस्पिटल बेंगलुरु में जो है वहाँ स्थित है और वहाँ वो न्यूनेटोलॉजी डिपार्टमेंट देखती है। आपको उस मॉर्निंग में मैंने बताया कि ये चीज़ मतलब जिसको क्या बोलते हैं अप्रोच टुवर्ड्स मेडिकल प्रैक्टिस, ये बहुत इम्पॉर्टेंट है और ट्रांसपेरेंसी और एथिकल प्रैक्टिस ये सब आज के दिन में बहुत रेयर हुई है। नॉट दैट ऑल डॉक्टर्स आर बैड, आई वोंट से लाइक दैट। नॉट ओनली बीइंग मेडिकल फ्रेटर्निटी करके नहीं, मैं खुद डॉक्टर हूँ इसलिए ऐसा नहीं बोलता हूँ, मगर सो मेनी पीपल आर देयर फॉर डूइंग गुड प्रैक्टिस। देयर एग्जांपल्स शुड कम टू द पीपल, स्पेशली पेशेंट्स एज वेल एज द अदर डॉक्टर्स आल्सो, सो दैट एक बात है नॉट वी हैव टू रन आफ्टर द मनी। हमारे जलगांव डिस्ट्रिक्ट के सीनियर मोस्ट एक थे डॉक्टर आचार्य, उन्होंने मेरे अस्पताल का इनॉग्रेशन किया था। तो उन्होंने बोला था तुम दरिद्री नारायण मतलब जो पुअर पीपल है उनकी यदि सेवा करोगे तो अपने आप लक्ष्मी उनके पीछे आएगी। तो नारायण की बीच भी है लक्ष्मी के पीछे भागोगे तो कुछ नहीं मिलने वाला।
100% true. 100% true.
So in this hospital since morning, talking with Dr. Prakash Mehta as well as other people, I could know कि ये हॉस्पिटल इसी तरीके के विचारों पे चलता है where approach is humanitarian. Especially pediatricians or neonatologists, many of the times they continue on ventilators. They do not allow parents to come to their place, meet the child. ये सारा चलता है कि अरे इन्फेक्शन हो जाता है, इन्फेक्शन हो जाता है, but still there are of course so many other things are there because of that infection comes and the thing becomes worse. We have to give heavy antibiotics and all that. So how you are having this approach कि आप मेरा बेटा और बहू दोनों अपने बच्चे से मिल सकते हैं, उनसे बात कर सकते हैं, उनको हैंडल कर सकते हैं, ये सारा आपका अप्रोच मुझे बहुत अच्छा लगा। So how you have developed this approach?
Thank you so much for all that wonderful words what you have used for us. It's it will boost our morale and will keep us going doing the job what we are doing. Thank you so much. Sir, हमारे यहाँ right from day one when we started the unit, we have got the parents actively involved with the baby care. In the sense, for us, the parents have all the right to know about their babies, be it good, bad, or worse. We don't believe in hiding things from them. Okay, it's not like we give them a rosy picture, tell them nahi nahi kuch worry mat karo, sab kuch theek hai. We tell them the facts. We tell them the facts. Yes, the baby is in this condition. This condition would require this intervention. There are risks, but yes, we will do our best. So we talk to the parents on a day-to-day basis. Keep them updated about the progress of their baby. The second thing is we find it very important to get the parents into the unit because it's their baby.
Yeah.
It's their baby. They have that right to think. Infection, yes, infection is a problem what we see in the NICU. But parents, when they know it is their baby, they are extra cautious. They make sure they wash their hands. They make sure they wear a scrub suit and then come inside. In fact, a lot of them are scared to touch the babies in the initial stages.
Yeah.
We gently take them, we ask them to touch the babies, we ask them to feel their babies, talk to the babies, sing to the babies. All these things are going to do good to the babies.
Yeah.
There'll be that bonding which is there. That will happen right from day one. Number one. Number two, the moment I start getting the mother involved, her confidence in dealing with her little baby will increase.
Yeah.
So she will be more comfortable and confident. She will get to know her baby, how her baby behaves. At the time of discharge, how to take care of the baby. So she'll be a more confident person going back home.
Yeah.
If I don't get her involved and send her away without training her how to take care of her baby, she will be lost. She'll be lost. With a tiny baby, they are completely lost.
Yeah.
So it has been our legacy to get the parents involved right from the day one. In fact, we have some wonderful fathers doing KMC. They would love to sit down and do KMC with their babies. And I find it really good to see the fathers being actively involved with the babies. It's really reassuring.
Yeah.
It feels good. So that has been our policy from day one.
Very nice, very nice.
Right.
Because that bonding, that relation,
Yes.
it also gives boost to the progress of the baby.
Correct.
That is what I
Correct.
feel.
We are not scared of having the parents inside. Yeah, of course, when we have any procedure happening and all, we request them, they go out. But then limiting their entry into the NICU, we don't. They have a thing to come and see their baby, visit their baby.
What about some suppose uneducated or lay people? If they are there, then what
Sir, I would say education has got nothing to do with this. What is important is common sense. That's a fact. That's a
very nice,
fact.
very nice, very
Education
true.
has got nothing. I would tell my parents, please don't go to Google. Okay, go to the elders at home. They are the experienced people. They will guide you in a better way than the Google.
Wow.
So
nice.
education has got nothing. What is important is having common sense.
Yeah.
And no education or no education, we have no issues.
Yeah.
In fact, we counsel them. They are very good at listening.
Yeah.
In fact, our rural people from the rural places, they follow your word one by one. They will not go that side or this side. If I tell them this is how it has to happen, they will do it. So that way they are very good. We have had no issues. In fact, the moment you connect to the parents, life becomes very easy, even if the baby is not doing well. Because the moment you connect to them and tell them what are the facts, this is what we are doing, this is how things are moving, things are not favorable, but we are still working on it, the parents are absolutely fine. But you try to hide things and do it, that is when the breach of trust starts. So we don't give any scope for that.
Very nice. Transparency is there.
We believe in that. We believe in that. We believe in telling the facts and facing the facts with the parents. That's how it is.
Secondly, which I like most is you started breast milk so early.
Yes.
So, what is your what is your experience and as well as your approach towards?
Yes.
Because many of the time, most of the pediatricians they start writing formula feeding at a very early stage, and Caesar, you are not going to feed the baby for 2 days, 3 days, like that they will say. In our hospital, of course, we prevent that, and we say, day one, you can feed the baby. No.
Yes.
So
what I have seen in our field, we are continuously learning.
Yeah.
We are continuously. There have been times when they say feeding has to be deferred for 48 hours, make sure baby is stable, only then start feeding. Then things, it's a very dynamic stage. Our field is a very dynamic, medical field is dynamic. So we need to go with the dynamics, how the things are changing. So presently, breast milk is something which will not do any harm to the baby. And especially mother's own milk. And we have to remember mother's milk also varies with the gestation. The preterm milk is different from a term milk. In the term milk, the milk which the mother produces in the first few days after delivery is very different from what she produces subsequently.
Okay.
So everything is tailored according to the need of that particular baby.
Baby.
So what happens? We are giving something which is tailor-made.
Yeah.
Whereas everything else will be like in bulk we are producing and we are giving. We don't know what is the baby's requirement. Whereas here, when we do the breast milk, it is particularly made for that particular baby. The mother's body knows it.
Very good.
So we believe in giving tailor-made stuff, not custom-made, tailor-made to that particular baby. So that is what we believe in. And we tell the mother that whatever little she produces, even that will do good, because the initial stages, colostrum, it is rich in so many protective factors. It will do the baby good rather than doing any harm to the baby. So we are going to take full advantage of it. Why not?
Yeah.
Why not?
Yeah.
So we are going to take full advantage of it. So we have been giving mother's milk. Babies have been doing very well. In fact, with the mother's milk, the chances of any issues coming in are very, very, very low. Even if you started on day 1 of life, nothing is going to happen. We have been doing well. And we have gained our confidence over a period of time. So we are now very comfortable giving the mother's milk. Yes, in certain medical conditions, we have to wait and watch. But otherwise, in majority of the cases, we give mother's milk. Yes, we do mother's milk. Even few drops, I have to go ahead, give it.
Yeah.
Mommy is happy, baby is happy, doctors are happy, parents are happy. So everybody is. So that's how we've been doing, and we've been doing pretty good with this, with the mother's own milk.
Secondly, what I like very much, being of the ventilator so early, and you try to give either non-invasive.
Correct. So that has been doing non-invasive ventilation has been a big boon for us. Big boon for us in the sense, now any baby with distress, we are not concerned about having the ventilator, ET tube and all. We immediately put the baby on the CPAP and leave the baby. And only if the baby doesn't show us response do we consider intubating the baby. And most of them do well only on CPAP. They do well, very well on the CPAP. And in case if it's an extreme preterm where we had to give the surfactant, we do the Ensure method where we intubate, give the surfactant, stabilize the baby, and once the baby shows good recovery, we get the baby off the ventilator and we put the baby on the CPAP.
Right.
So by putting on CPAP and doing less of the invasive procedures, the baby's recovery period will be better. We will be using less high-end antibiotics, and as a doctor, I'll be more than happy to do all these things. Less invasive food for our babies.
What is your opinion about preventive antibiotics? Many times if they are given.
So we don't do any preventive antibiotics. Just because a baby is born preterm, if the mother has no risk factors, we do not give antibiotics. Okay. And even if the baby is having respiratory distress, we wait and watch. We wait and watch for a few hours. If the distress is getting worse, if there are some factors in the mothers, only then we consider giving antibiotics. We do not do any preventive antibiotics at all.
Very good.
No preventive antibiotics. We start off with basically have grade 1, 2 and 3, where we start with grade 1 level of antibiotics, first line, second line and third line. So, and then we sort of upgrade it depending on the situation, only if the situation asks for it. Otherwise, most of the babies, when required, are on line 1 of antibiotics. We are scared of higher end antibiotics because the chances the chances of cross resistance will go high, and we will be left with no other antibiotics when we really require it. So no unnecessary antibiotics, and even if we start, we try to get the baby off the antibiotics at the earliest once we have our cultures coming positive, I mean negative. Yes.
Okay. Secondly, what I feel, of course, mother's milk and formula feed, you have given the explanation. Prednisone, or steroids
Yes.
given in antenatal period.
Correct.
What is your observation?
So it is a lifesaver,
Hmm.
provided we use it in the right way.
Huh.
Okay, so you can give maximum 1 to 2 course.
Hmm.
You cannot keep on giving it every week. There are some institutes where they keep on giving preterm, high risk delivery. Every week you keep on giving steroids. No.
3 doses, that is what we are doing. One in the morning and
No,
after
no.
12 hours and
That is one schedule.
Hmm.
Okay, maximum 2 courses like this you can do. Suppose you have given it very early, say at about 26, because the lady had some issues. Now she's at 34 weeks.
Hmm.
Okay, yes, we can do. Up to 2 courses of steroids can be given.
Huh.
It has done wonders in the lung maturation. All the antenatal interventions like your steroids, your Maxilf infusions, all of them have definitely done good in the babies, in the sense the lung maturity is better. The chances of brain hemorrhage is less, especially when we have mothers with Maxilf infusion. So all these are necessary. We would definitely advocate it. Definitely we advocate it.
Definite improvement in the
Definitely,
babies.
sir. Definite improvement is there. Definite improvement is there. We would strongly recommend antenatal steroids and Maxilf to the mothers when she is in prep for a preterm delivery.
Secondly, what period you feel ki now, bus, now we have to take the baby out. So, of course, that is more for Dr. Prakash Mehta, it's the obstetrician's decision.
Correct.
But it's like, see, at this week's, okay, we can save the baby.
So let us be very practical in our setup. 26 weeks and above is our limit. Below that, no, we cannot do good below that. 26 weeks and above, yes, we are comfortable. And babies who are about 700 grams and all, we are very comfortable.
Okay.
Though our tiniest survivor has been a 550 grammer.
Wow!
But 700 grams and above, yes, we are comfortable. 26 weeks below that, no, we are not. Though the medical science has made
20 weeks is the
yes, but then
like,
what I personally believe is, it is not giving a baby which is important. It is giving a
healthy.
We don't want a baby to go. We want a baby who's got quality in life.
Yeah.
Because the more preterm, the more issues we are going to have in these babies. And in our Indian setup, taking care of a baby is becoming challenging. If you ask them to take care of a baby with special needs, it is going to be a big, it's going to be a challenge for the parents. Yes. So our aim should always be to give a baby with good quality of life. We can do our best. Of course, there are some situations which you cannot help, but our best to give, I believe in giving quality. Okay, we do try. Any baby which comes our way, we do try. We counsel the parents. We are very realistic when we talk to the parents and telling them, see, this is how our statistics are. This is how we have been doing. This baby is in this situation. We will do our best in this situation. Being realistic is very important. That's what I mean.
Yeah. So, what I feel, your counseling part is very important.
It
and
is.
that you people are doing very nicely. So
No. Yes, because whenever we face a baby who's very preterm, like I told, I have to be realistic when I'm talking to the parents, but at the same time, I shouldn't be demotivating them.
Yeah.
Whenever we have a baby who's less than 1,000 grams, all the risk factors are going to go high. Okay, so the first time the father comes, he is overwhelmed with the situation that his wife is going through a preterm delivery. We are having a baby. I cannot sort of get him more agitated by telling, look, the brain can have this, the lungs can have this, this can have this. So what we can tell them gently is, yes, we have a baby. This baby is going to have certain challenges.
Yeah.
We are equipped to face these challenges. Let us see how the baby is going to take the situation. And tell them, we'll take every day as in how it comes and then face the situation. Being realistic is what is very, very important. And that is what I have seen, even in the bad scenarios. If you are realistic, the parents definitely appreciate it.
Yeah.
Even in bad scenarios. They appreciate, because we had told them everything. We had told them, look, the situation is like this, things could go wrong. We always hope that things go well. But yes, I always believe in hope for the best and be prepared for the worst. That is our motto. We always hope for the best, but we are always prepared for the worst.
Way of presenting it, very important.
It is important, sir. It is important. Like I've had, when my patients come to the OPD, I've had the mothers coming and telling me, कभी तो शुभ शुभ बोल दीजिए डॉक्टर साहब. I told them, भी शुभ शुभ बोलेंगे तो आप हमारे पास नहीं आएंगे. That means I'm telling you only lies. I have to tell them what is the reality. So they were, but at the end of the day, they come back. So what happens, like the way the mother develops a relationship with the obstetrician, by the time the baby gets discharged and goes out of the NICU, they develop a bond with my girls, with us. So somehow we become a part of the journey for them, with the baby NICU journey. So it's nice. We have wonderful things happening. There's a lot of satisfaction in the job. When I see the parents going back home happily with their babies, when I see them waiting in anticipation and they go home, I mean, that's a joy which is no amount of money can give you that satisfaction and joy.
Of course, there must be many cases, but do you remember one case which was like, अरे मेरा life बन गया इसमें?
Yes, we had one case recently. We had this mother. It was a late preterm baby. Baby was about 1.9 kilos. I had told once the mother was running fever. I told once the mother's fever is reduced, that the baby gets discharged. And in the night, the baby threw a fit. And next day when we did the LP, the baby had meningitis. And it is meningitis of a very rare organism called Escherichia coli. This bug attacks only the brain. Chances of survival are very low. And even if the baby survives, the chances of hydrocephalus and brain injury are very high. That was the first case I had seen in my 25 years. That baby is now what? She'll be 2-3 years now. So it was IVF pregnancy, precious pregnancy. And I went to the parents and I told them that I don't know what I'm dealing with. Because this is the first time I'm dealing with. And even the hospital, we try to find out from there. They only take reports of such cases in the NICU. We did everything and we gave the baby antibiotics for 3 months. IV antibiotics for 3 months. The baby recovered and lived. It was
very good.
I was really, really apprehensive about the patient, about the thing, because they are only case reports.
Yeah.
But yes, the baby would go. And I would give all the credit to the baby, because I always tell the parents when they tell you have done everything, I didn't do anything. If there's anyone who has fought it out here, it's the baby. If the baby is with us, we win the case. If the baby decides to go against us, nothing works for us. So whatever it is, we stand with the baby, we give the arms and ammunition to the baby. Just antibiotics वगैरह दे देंगे हम. लेकिन fight कौन करेगा? Baby को ही करना पड़ेगा. So the amount of fighting my babies do, any adult would have given up. The babies fight it till the last. So I say we have a lot to learn from the babies. The one attitude what I have learned from my babies is never give up till the last. They can change. They can change.
Yeah.
So don't give up. So that is what I have learned from my babies. They fight it out. They really fight it out. And hats off to them. And other thing what I have noticed is sometimes what medicines cannot achieve to a full extent, the parents can. The mother's touch, the father's touch, they come in and talking to their babies. They do a lot good to the babies. So getting involved, parents getting involved will do a lot good. So I strongly believe that they must, like KMC, whenever they're doing KMC, you must see the vitals, how beautifully they stabilize. A baby,
KMC, no.
it is kangaroo mother care.
Kangaroo mother care.
Skin to skin contact जो होता है baby के साथ. Any baby, if you see the moment you start KMC, the baby is so beautifully relaxed, you know. So their vitals go down, the stress levels go down. So it's, and we must see the satisfaction on the mother's and the father's face. When they are sitting like this, it is worth seeing. It's a beautiful picture. I mean, I really feel happy when I see the mother and the baby. The mother feels so complete when she has a baby on her. It's a beautiful thing to watch. Yes. So all these small things, they appear very small, but they can do a lot of difference for our babies. Mothers KMC, mothers getting involved with their baby care, all of them. When you keep them away, then there is always a doubt कि अंदर क्या हो रहा है. Whereas if they are there on the scene, they know, yes, this is what is happening. This is the problem my baby is facing, and the doctors are doing this. So that gives them a lot of confidence.
Yeah.
So I don't believe in keeping them away. I believe in taking them along with me in this journey. That's very important.
Only one question now. Ki, whatever empathy, sympathy you give to the people and all that, that is not a, it's like individual job, it's the job of a team. So how you give the same spirit to the students, to the nurses, to the staff, to everybody? How you transmit it to them?
My unit is my second home, sir. My NICU is my second home. And yes, I tell the parents very specifically, don't sort of, not parents, the attenders, don't come and disturb the baby, disturb my staff, because the main work what the staff is supposed to do is take care of your baby. Every time we have an attender coming in, asking me, how is the baby? We have one attender coming now, we have second attender coming down, third attender. I tell the girls who are supposed to take care of your babies are stopping doing that. And they're coming and answering you. So what is that you want? You want them taking care of your baby, or you want them to talk? Talking, you have anything, the parents are most welcome, we talk to them every day. That's one thing. Second thing is, I believe in standing with my nurses. Good, bad and worse. I stand with them. At the same time, if there is anything which is not going right, I correct them. There is a very, what I should say, we have no inhibitions. The girls have no inhibitions. Anything they want, they ask us. I keep on teaching them on a day-to-day basis about counseling. Yes, I have grayed my hair and reached this level. They will not have my level of patience. At times they tend to lose. I don't know. Put yourself in their position and see. What they require is a few good words. Yes, at times they can be angry, at times they can talk a little out of the way, but then remember their situation. They're talking because of the situation they are in. Put yourself in that situation. You remain calm, they will calm down. You get agitated, they will get more agitated. The moment you're calm, it is life is a mirror. What you give, you get back. So from the other side, even if they're agitated, you remain calm. You keep on talking to them, they will relax. So all these things, sadly medical field don't teach us about counseling and all. This I think is what we learn over a period of time. But then yes, I think as a team leader of the thing, I believe in keeping myself very cool and calm in any situation. Only then my girls will be able to work in a thing. Suppose there's an emergency, I tell them no jumping around, otherwise you'll commit a lot of mistakes. Remain cool, calm. We have a protocol, just follow that. We have just follow the protocol. Okay? If you get agitated, पूरा mistakes होना शुरू होता है. काम ले जाओ. ठीक है, जो करना है करो. Help बुला लो. ठीक है? No agitation, no getting क्या hyper नहीं करने का. No getting hyper. काम लेना है. Baby दिख हो रहा है, ठीक है. आपको जो करना है शुरू कर दो. डॉक्टर्स को बुला लो. So keep doing what you're supposed to do. Remain calm. That is the mantra. That is what I do. And yes, I have had very wonderful feedback right from the beginning. My staff, especially my nurses, in any closed unit, you know that your nursing staff is the backbone of the unit.
Yeah.
That way, yes, I have been blessed. Of course, like I told you, so every day is a learning experience. Anytime we have any issue, we sit down, we discuss, we dissect it completely, we get to know where it is, how it is, and we try to improve ourselves. We take feedback. Anything which is there, I believe in healthy criticism.
Yeah.
We can't see our own back. So if there's any criticism, we sit, we analyze it. If it is healthy, we take it. If it is thin, then we just let it go.
Let it go. That is also very important.
Very important. See, you do have in our profession, you know, when things don't go the way the parents had anticipated, sometimes they can get a little aggressive. But yes, we have learned to take everything in our stride after explaining everything. So that is what it's all a part of the show. We have to continue it.
मुझे लगता है कि आप लोगों से मतलब डॉक्टर प्रकाश मेहता as well as you we have received a very good message, you know? एक तो मतलब जो आपने बोला कि काम रहना चाहिए any time.
Yes, very important.
And have a very good conversation with the parents
very
and with the relatives,
very
so that things go well.
It is being. I mean, tell them the facts. What are the facts? Yeah. So what I see is complications are a part of the show. Complications are not equal to negligence.
Yeah.
Complications are not equal to negligence. That is what we need to make the parents understand. See, these are the complications. Your baby can have this. If that occurs, that is not negligence, it's a complication. Not delivering your due for that particular baby becomes negligence.
Yeah.
Complications are a part of the show. Any profession has got its complications.
Yeah.
But if you have been transparent about it, telling them this is what it is, this is what it is, yes, we can face them together.
Very nice. Thank you very much.
Thank you so much.
Especially from our YouTube viewers and our patients, our doctor friends and everybody. Because you have given a very good message for everybody.
Thank you,
Patients as well.
Nice talking to you. Thank you so much.
धन्यवाद.
Thank you so much.